Interventions with a King. Discussion and commentary based on articles from JACC, Cardiovascular Interventions.
I'm Spencer King. I'm editor of JACC Intervention. I'm visiting today, very pleasurably, with David Canzeri, who's at Scripps Clinic. David, welcome.
Thanks, Spencer.
Listen, we've got a big problem in interventional cardiology. We've got drug-eluting stents, which are now very popular, and yet we insist on double antiplatelet therapy for a reason. We're concerned about late stent thrombosis. How big a problem is a question, but there's no question that everyone is concerned about how long to give these things. You've written an excellent paper for us reviewing this in an issue, a focused issue of JACC Intervention that deals with second-generation drug-eluting stents. Tell me your thoughts on double antiplatelet therapy. How long should we use these things?
Thank you. Ever since 2006, as you say, stent thrombosis, and especially this seemingly unpredictable occurrence of very late stent thrombosis, is really the driving safety factor in drug-eluting stent utilization today. And probably the greatest dilemma or uncertainty for us is what the so-termed optimal duration of dual antiplatelet therapy is. And when we look closer into the evidence basis, it turns out that the evidence basis is actually far less than optimal for helping us understand whether long-term thienopyridine and aspirin treatment actually reduces the risk of stent thrombosis. We know from a series of trials that it may perhaps reduce death and myocardial infarction, and we're treating a systemic disease, we're treating the patient, but we may not really be treating the stent territory in preventing stent thrombosis.
So right now we're talking about guidelines, say, a year for most of these things. Where did that come from?
So it turns out that the guidelines decision is very much consensus opinion based, for one thing, and it's further based on observational data that has suggested that early discontinuation of antiplatelet therapy, and especially both aspirin and thienopyridine, but thienopyridine alone, and especially within the first 6 months, is associated with an increased risk of stent thrombosis.
Some people are confused about this early thing. What early meant earlier than the recommended on the label of the stent? Is that what it meant?
Yeah, that's a great point. Actually, it means different things to all the different studies. And in fact, in probably the most widely cited trial about early discontinuation, the timeline for early is never defined. And so part of our purpose, among many in this manuscript, is to redefine the discontinuation timelines. And we define early as less than 6 months, late as 6 to 12 months, and very late beyond 12 months. A little bit analogous to stent thrombosis, but at the same time a bit different too.
So a lot of interventional cardiologists, but perhaps even more primary care physicians, internists, and non-invasive cardiologists caring for these patients are in a dilemma. How long should they give these things?
So at present, we don't have, even for what generated the guidelines as we were discussing, we don't have any large randomized clinical trial data as of yet for different durations of dual antiplatelet therapy. And so much of it is predicated on large observational studies. But these studies indicate that even with first-generation drug-eluting stents, that continuation beyond, say, 6 months is really not mitigating the risk of very late stent thrombosis. And as the treatment patterns have changed in very recent trials that we've seen just this year, for very late stent thrombosis after 1 year, we're seeing at least as many, if not more, late stent thromboses occurring while patients are on dual antiplatelet therapy than off of it, or at least off thienopyridine treatment.
So we got studies now that are going to compare a year to even longer periods. But the question I want to end up with is, does one size fit all, or should we be sorting out which ones are at risk?
That's right. So just in the past year, the waters have become even more muddied, because the question is not only what is the optimal duration, but is the optimal duration the same for each type of drug-eluting stent? And we've seen very recent data highlighting differences both early and late between drug-eluting stents. And the second question is the optimal duration the same for every patient? As we know that there are inherited platelet polymorphisms, there are different responses to antiplatelet agents as well. And so there are a number of ongoing studies too, such as the Seaside trial that we're performing, that is looking at not only shorter durations, but trying to tailor therapy to individual patients based on their genomic makeup or their antiplatelet response.
So we got a lot to learn. I appreciate you studying this, and we've got a lot of work to do. invite everybody to have a look at your article, because I think this subject is going to be one that's going to be with us for a while. Thanks very much, David, for visiting with us.